So good evening all and welcome to eGurukul for today's session. Our panel discussion on little guts, big challenges, pediatric IBD in focus, and that will be followed by a sensational quiz on the abdominal system, which we learned for the last 3 Thursdays and today also with some learnings. For this e-Gurukul session, I invite our Jankhana Madam, President AOPG, for her welcome address.
Thank you, Dr. Nehal Madam. Good evening and welcome everyone. I welcome Project Incharge Dr. Yogesh Parikh sir, Moderator Dr. Vishal Vaghwan sir, Panelist Dr. Shruthi Badrinath, Dr. Ankash Agarwal, Dr. Bhushan Arun and Dr. Prasad, and I welcome Quiz Master Dr. Prashant Karya. I welcome AOPG Secretary Dr. Nehal and Dr. Lata Jha as a program coordinator. I welcome all my EBs, OBs and all delegates. Abdominal system e-Gurukul program is now reached to a new heights, and I am 100% sure that this program is become a fruitful to so many people. Not taking much time. Over to Nehal.
Thank you. Thank you so much, Madam, for the nice welcome. Now I request our visionary, Dr. Yogesh Parikh sir, whose vision came true a long ago, and now we all are getting fruits of that vision, and that is Gurukul PATHSHALA. So Yogesh sir, please.
Yeah, thank you, dear Dr. Nehal Patel Madam, and respectfully our President Dr. Jankhana Sangvi Madam, Dr. Nehal Patel Madam, Dr. Prashant Karya, and our West Zone Vice President Dr. Sandeep Trivedi, Coordinator Dr. Lata Jha, in the absence of our convener of the program Dr. Baldev Prajapati sir, Moderator Dr. Nishant Wadhwa, Panelist Dr. Shruthi, Dr. Ekansh, Dr. Bhushan, and Dr. Prasad. We are very much thankful to all of you for receiving and honoring our invitation in the last moment, and you prepared this presentation on the little guts, big challenges, pediatric IBD in the focus. And our treasurer, Dr. Prashant Karya, has a wonderful quiz, and exciting prizes will be there. So let us learn from the panelists and have a quiz session after that. So be stayed with till the last moment to win the election. This is our prize distribution. Thank you. Thank you very much. Over to you, Nehal Madam.
Thank you so much, sir. And motivating everyone to join and learning, along with that, getting something from the learning, not only the knowledge, but also the testing of the knowledge by quiz. So with this, I hand over this platform to Dr. Lata, our chief coordinator for this project, to introduce the moderator and panelist. Dr. Lata.
Thank you, ma'am. Thank you for your kind words. Good evening, every senior faculties. I'd like to introduce our moderator for today's panel discussion, Dr. Nishant Wadhwa, sir. He is Senior Consultant and Chairman Division of Pediatric Gastroenterologist and Hepatology, Pediatric Liver Transplantation at prestigious Gangaram Hospital, New Delhi. Our panelists for today are Dr. Shruthi Badrinath, ma'am. She is Consultant and Pediatric Gastroenterologist at Aster Hospital, Bangalore. Dr. Ekansh Agarwal, sir, he is Consultant and Pediatric Gastroenterologist at Bareilly. Dr. Bhushan Arun, sir, he is Associate Professor RCSM, Government Medical College, Kolhapur, Maharashtra. And Dr. Prasad BS, Consultant Pediatric Gastroenterologist at AJ Hospital and Research Center, Kids Gut and Blood Clinic, Mangalore. Welcome all the faculties, all the panelists and moderator. I'll hand over now next to Nehal Madam. And in fact, I'll say Dr. Wadhwa sir to continue the program.
Thank you. Thank you very much. And thank you, Dr. Parikh, for this kind invitation for this special e-Gurukul session. It's good to be here. So we are going to talk, and I welcome my panelists, Dr. Shruthi Ekansh, Dr. Bhushan, and Dr. Prasad. What we are going to do in the next 45 minutes would be to take you through the journey of inflammatory bowel disease in children and why and how it is important for a pediatrician to pick this disease early in course, and what are the pointers towards it. I have an esteemed faculty of panelists here. I would just urge them to be brief in their answers so that we are able to go through the panel quickly and succinctly.
Yes.
So, thanks everyone. So I'll move on to the presentation now. So now we know that inflammatory bowel disease in children is now being increasingly picked up and diagnosed and well treated as well. There has been an increase in incidence as well as the pickup rate has improved. The group of conditions which cause long-term inflammation of the GI tract. So my first question is, what are the various types of disorders which are classified under IBD, and how much of these actually contribute to the overall disease prevalence? Dr. Shruthi, would you like to answer this question?
Yes. Thank you. Thank you for the question, sir. At the outset, I would like to thank Gurukul PATHSHALA for giving me this opportunity. It's great to be here. To address the question, inflammatory bowel disease is generally classified into Crohn's disease and ulcerative colitis. These are the two major types. Sometimes we are not able to differentiate between the two, and there is an entity called as indeterminate colitis. Amongst these three, Crohn's disease is more common. We see it nearly in 60%. Less commonly in ulcerative colitis, nearly 25 to 40%, and the least common is the indeterminate colitis.
So thank you, Dr. Shruti. And so what essentially are the differences, if you could just point out, between these two varieties of IBD, three varieties of IBD?
All these three entities differ in based on history, clinical examination, endoscopic findings, and also the biopsy features. So there are differentiating features for each one of these. Just to put it in simple words, Crohn's disease includes the entire GI tract, that is anywhere from the mouth to the anus. There is inflammation anywhere along the tract. Ulcerative colitis mainly involves the colon. So that is the characteristic of ulcerative colitis, and indeterminate colitis can be having overlapping features of either of these two.
Thank you. So now that we know what it is and how different these entities are, and Dr. Ekansh, what is the incidence of inflammatory bowel disease in India? And do you think this incidence is any different from the Western countries or the Western world? Because earlier it used to be said that IBD in children is a disease of the West rather than our own country. And if you feel this incidence has increased, what could be possibly the reasons for this increased incidence of IBD in India?
Thank you, sir. So the incidence, as we said, that the incidence of Crohn's disease is more as compared to ulcerative colitis. Also, the incidence of IBD in India has been always on the increasing trend, and almost the studies these days have suggested that the incidence is almost catching up with the Western literature. And also, it depends on which part of the country, probably in the North India versus the South India, where in North India it's more of ulcerative colitis. And the trend could also be due to the lot of multi-factors. One of them being the use of processed foods, which we've seen has been on the increasing trend in our country, which was only there in the Western world before. And other than that, there could be some environmental factors or the gut microbiome, and also sometimes could be hygiene hypothesis. But again, we may not be able to get one definitive reason for having IBD in any given child.
Yeah. So definitely the incidence of IBD in India is as high or as low as compared to the West. And with the increasing number of cases being picked, it's very important for our pediatrician colleagues to be able to identify these children in their busy OPD practice so that they are picked up early and treated early. So the incidence is pretty much similar. So we know that inflammation of the bowel is what presents as IBD. So my next question here is, what is the age at which this actually presents? Is there a particular age predilection for pediatric IBD in children, or we have actually particular age groups or age subsets where one would find this disease more commonly? And so this question is addressed to our next panelist, Dr. Bhushan Arun Miraje. Dr. Bhushan.
Yes, sir. Thank you, sir. So, along with this classification, according to the onset, also we divide IBD as a very early onset IBD, childhood onset IBD, and adolescent onset IBD. So, the child who presents with the signs of IBD with less than 6 years old, mostly they present that we label them as a very early onset IBD. That is a 25% of cases they present in a very early onset of IBD. Childhood onset is between 6 to 10 years of age, which is the age group is 20%, and adolescent usually by the second decade. So between 10 to 17 years, if they present, that is called adolescent onset IBD, the presentation is very 55% cases are they usually present in this age group. So presentation of ulcerative colitis and Crohn's disease. So there is a bimodal presentation of IBD with peaks in adolescent and fifth decades. So adolescent is a high risk age group where the presentation is more. They present with the signs of IBDs.
So to just sum it up, yes, IBD is more common in certain age groups, adolescent age groups being the more common ones. But then there is a distinct subset of very early onset IBD, which occurs in less than 6-year-olds, which constitutes about 1/4 of the cases. And then there is childhood onset IBD between the 6 to 10 years of age, which constitutes another 1/4 cases. So there is a bimodal presentation of IBD.
Yeah.
So next question to Dr. Prasad here. So, Dr. Prasad, how is pediatric IBD different from adult IBD? Is there a difference, and is it important? The way we diagnose, the way we treat these children, how different it is?
Warm good evening to all of you. Thank you, Gurukul PATHSHALA, for the opportunity. As Dr. Nishant has pointed out, this pediatric IBD compared to adult IBD may be of severe phenotype, involving the more extensive involvement, starting from small bowel, large bowel, even the upper GI involvement. And they may have more severe disease at onset and may have higher chances of complications like fistula or a stricture, etc. And at diagnosis, they may be undifferentiated. It may not be differentiated from Crohn's disease or the ulcerative colitis. And the subset of children where there may be a fraction of a disease where it may be a monogenic form, or what we call it as inborn error of immunity or primary immunodeficiency disorders, where IBD may be only a part of the disease or a part of a systemic illness. Since these children are in the growing age group, our treatment targets are to achieve a good remission, as they are in the growing age group and they have a longer lifespan to live. So we often may follow a top-down approach where we are starting with the higher lines of management like biologicals, etc., especially when the child presents with the severe phenotype of the disease, and then stepping down once the disease is in remission.
Yeah, thank you. Thank you, Dr. Prasad, for excellently putting it. So, pediatric IBD is different from adult IBD, and it is a more extensive disease. And herein lies the difference both in diagnosis and management, and why we see that many such patients are even today, being managed by adult gastroenterologists, and they do not receive adequate therapy, which is due at their age. So, it's important to refer these children early to a pediatric gastroenterologist for this reason. But Dr. Shruthi, do you think IBD is being missed in children? And what could be possibly the reasons in our own country why IBD could be missed? And why is it important to pick it up early, where it can be mixed up with some other disease?
Yes, so I think IBD is probably being missed a lot more. It was missed a lot more earlier. Now we are picking it up a little better, but I don't think all of them are still being picked up. It could be because of multiple reasons. When we start off from the history wise, we do not have there could be vague symptoms which are not very clear, and the pediatrician might not be sensitized that this could be a pediatric IBD. So that is at the history level and at the examination level, it could possibly be. That could be one of the reasons as to, because since we are not sensitized, we are missing it. We are not even evaluating for it. Now, let's say we have started evaluating for it. Even the evaluation is a little tricky because it is like putting like a jigsaw puzzle of the clinical history, examination, endoscopic findings, and the biopsy. So that again becomes a little tricky. And apart from this, we know that in IBD, that is especially the Crohn's disease, is very similar to tuberculosis, that is a TB of the GI tract. So it could possibly be, there could possibly be the reason that most of these cases are being treated as TB instead of being treated as Crohn's disease. So looking at all these reasons, that is from the history, examination, and also evaluation, where we have similar endoscopic findings and we do not have very, very characteristic biopsy findings. We know that many times it can just overlap. So looking at all these things, there is a possibility that that IBD diagnosis is being missed in children.
Thank you. Thank you very much. So yes, it is being missed, and the reason being tuberculosis endemicity in our own country, which is mimics IBD very succinctly, especially Crohn's disease. So a clinician can actually misdiagnose it if the certain protocols are not followed, which we will come to later on. So for the pediatrician's benefit in his busy OPD practice, clinical practice, what, according to Dr. Ekansh, what do you think are the red flags which should alert a pediatrician that possibly this case I am seeing in my OPD could be suffering from IBD? And if so, are these red flags different in Crohn's, suspected Crohn's versus suspected ulcerative colitis? Let's start with the red flags for suspected Crohn's disease. Okay.
So as said earlier, the Crohn's disease can involve any part of the intestine and more of the small intestine. So what you get is the growth failure because of the persistent inflammation which is going on for a long period, and is the chronic diarrhea that would be there in Crohn's disease, and recurrent abdomen pains. And once you have a child who's having recurrent abdomen pain with the chronic diarrhea, with growth faltering, and you go for the investigation, you may have raised inflammatory markers which would remain persistently elevated despite your basic management which you want to give. Sometimes there may be subtle signs that may be present in one of the other cases which actually guide you towards that child could be having IBD, like recurrent aphthous ulcers or any perianal involvement like fistulas or abscesses, or sometimes your anal fissures. But when we talk about yes, sir.
Yeah, go ahead.
So when we talk about the ulcerative colitis, it is more of the colonic involvement, that is the large bowel involvement. So the symptoms are more like a large bowel involvement, like you'll have a
So I let Dr. Bhushan take that question. Dr. Bhushan, what do you think are the red flags for a suspected case of? So Dr. Ekansh has just enumerated for a suspected Crohn's disease. What are the red flags for a suspected ulcerative colitis?
Sir, either any child who presents with a persistent large bowel diarrhea, specifically with the blood or mucus in the blood stool, pain in abdomen. So if the child has a nocturnal pain, so pain in abdomen, child wake up from the sleep, that is also significant. Along with fever, sometime may be there, may not be there. Tenesmus has to be there along in a suspected case of ulcerative colitis. As compared to Crohn's, failure to thrive may be there or may not be there. But as it is more commonly seen with the Crohn's, ulcerative colitis child may have failure to thrive or may not be there. But if the blood, abdominal pain with nocturnal complaint, fever, tenesmus is there with a large bowel diarrhea, we strongly suspect ulcerative colitis. And many of the times we have seen lots of times someone has they give a trial of multiple antibiotics and they're not responding to or incomplete response to antibiotics. In that case also we can suspect ulcerative colitis. Any diarrhea, chronic diarrhea who presented with persistently raised inflammatory markers. So child has a high CRP with a leukocytosis, thrombocytosis, high ESR. That is in the favor of, we also suspect we are dealing with something chronic diarrhea in an inflammatory condition. So that's also favor. And as Dr. Ekansh says, we can get extraintestinal manifestation in ulcerative colitis too, like uveitis, aphthous ulcer, erythema nodosum, primary sclerosing cholangitis, and arthropathies. So all these are the can be associated manifestation in a ulcerative colitis.
Yeah. So thank you. Dr. Prasad, so you have some red flags in your patient. A pediatrician comes across certain red flags in his clinic. So what 4 investigations he or she can perform in this such a suspected case to which would help him guide that, okay, this is the child which he should be referring to a pediatric gastroenterologist, and probably this is the child which is not suffering from IBD, he should be thinking of something else. But what of these tests, what percentage of the IBD patients can have normal lab parameters, and why do you think could be the reason for the same?
After taking a good history and a comprehensive examination, whenever we are finding any red flag signs, the screening investigations what we often use are, the first is the complete blood count, where we might find low hemoglobin, anemia, severe anemias, and platelet being an inflammatory marker, there may be thrombocytosis. The next 2 investigations what we often use are C-reactive protein and ESR, which may be often elevated. And then the next investigation is total protein and serum albumin. Since there will be non-selective loss of protein, there will be low total protein and serum albumin in these children. And as there may be 20% of the cases where it may be an evolving disease with not much extensive involvement of the gut, we may find all this investigation being normal initially.
So, as rightly pointed out by Dr. Prasad, there are certain pointers in investigation. For example, a low hemoglobin, which could be either secondary to multiple nutrient deficiencies or as an anemia of chronic disease, along with thrombocytosis, which is a marker of intestinal inflammation, similarly to any inflammation elsewhere in the body, and a raised CRP or ESR, with hypoalbuminemia, which is again indicating malabsorption in these children. So these are the pointers towards intestinal inflammation, which with a proper history and examination could be the pointers for further workup vis-a-vis the upper GI endoscopy and colonoscopy. But since pediatric age group, it's an evolving disease. As they grow older, the disease might manifest in its full form. So you might have 20 to 30% kids whose labs would be normal, but they are still presenting to you with some symptoms and pointing you towards this direction. And these are the kids wherein one has to have a high index of suspicion and perform endoscopies early to look for microscopic disease. So, Dr. Shruthi, over to you. So, there is this test called fecal calprotectin, which is now increasingly being used in various disorders. And what is its role in pediatric IBD, according to you?
When we are ordering for fecal calprotectin, we need to understand the interpretation should be done very judiciously and not solely based on the report of fecal calprotectin. So many times it is useful for screening in few conditions. Now, the fecal calprotectin can be either falsely positive or even falsely negative. So, in any infection of the intestine, let's say there is colitis, diverticulitis, or just use of NSAIDs, or even if you are using in children less than 4 years of age, it can be falsely positive. Or sometimes it could actually be a case of IBD, but it could just be normal in such a situation. So, it could be falsely negative as well. But we still use fecal calprotectin in children greater than 4 years of age. And generally, when it's more than 100 to 150, we do consider that as positive. And we consider the possibility of inflammatory bowel disease, but it only tells us that we need to go ahead and perform an endoscopy and a colonoscopy. It does not confirm the diagnosis. It indicates that we really have to go forward with further investigation. And it does not, again, differentiate between the types of IBD. So hence, colonoscopy is required. However, it is useful in cases when we are confused between IBS and IBD, because both of them might present with pain abdomen and loose stools. In such a situation, we can get a fecal calprotectin done, but we need to interpret it judiciously based on the clinical history, examination, and other parameters as well, like other inflammatory markers, what Dr. Prasad has just mentioned.
Yeah, so don't use fecal calc. The message is don't use it to diagnose IBD. Don't use it in less than 4-year-old children. And it is only to be used as a follow-up measure to assess disease activity in a known case of IBD. It does not actually help in diagnosis of IBD in any given scenario. So moving on to Dr. Ekansh for the next question. Okay, this has already been discussed that it's inexpensive, quick and non-invasive, but as Dr. Shruthi pointed out, it's very specific areas where it can be used. So moving on to the differences between these two important subsets of inflammatory bowel disease in children. Dr. Ekansh, what according to you are the differences, major big 6 or 7 differences between these two types of IBD?
So, as we have already discussed, between Crohn's and ulcerative colitis, if we talk about the clinically, you'll have small bowel symptoms more in your Crohn's disease, as well as large bowel symptoms more in ulcerative colitis, talking about clinically. Apart from that, the fever and the weight loss is more common in Crohn's disease as compared to ulcerative colitis. The extent of Crohn's disease can involve any part of the small intestine or the large intestine. And but talking about ulcerative colitis, it usually starts from the rectum and involves the upper part of the, like from the rectum towards proximally in the large colon. And also it is continuous in ulcerative colitis, where in Crohn's disease there could be patchy inflammation where you may get some areas in between which are normal as well. Also the perineal involvement, if there is presence of any fistula or any fissures in a child, then you suspect Crohn's disease versus as compared to ulcerative colitis. Because of that reason, there could be more of stenosis in Crohn's disease, and you rarely find it in ulcerative colitis. Histology-wise, there would be presence of granuloma on the biopsy, along with submucosal inflammation with crypt abscess and crypt distortion. However, in ulcerative colitis, there will be features of chronic colitis and crypt abscess and crypt distortion. So that is histology-wise, but very important is to be able to differentiate clinically also on the symptoms, so that sometimes the biopsy findings may be overlapping. It becomes a bit difficult to differentiate between Crohn's and ulcerative.
Yes, so to actually put it in bullets, the differences between Crohn's and ulcerative colitis are in the terms of disease extent, as well as disease depth of inflammation, as well as the areas of involvement, as well as their complications vis-a-vis stenosis and strictures, which are more common in Crohn's. And of course, both of these disorders can only be diagnosed by a pediatric gastroenterologist on endoscopy and biopsy. So we need a trained histopathologist to help us make a diagnosis. And there are times when one may land up in gray zones and be unable to actually differentiate it in the initial presentation. So, Dr. Bhushan, how is a definitive diagnosis in IBD made? And what are the tests which helps make a definitive diagnosis? And in continuation with it, in a bleeding per rectum child, you're suspecting IBD, he goes to, can you just order a sigmoidoscopy? Is it sufficient or something else needs to be done? So, in short, what are the guidelines for endoscopic diagnosis in pediatric IBD, and how are they different from adults?
Yeah. So for the definitive diagnosis, as it is just now we have discussed, the endoscopy is mandatory to confirm the diagnosis. So if all these red flag signs or suspected case of IBD, we should go consider endoscopy, upper GI and colonoscopy both. Even if you are suspecting only ulcerative colitis, you have to do the both. So because many times backwash hylitis or sometimes just a milder form or evolving form they can miss. So it's always better to do upper GI endoscopy recommended along with the colonoscopy. That is what I think which is classically differentiate from the adult gastroenterologist, because the adult they do the only colon and even they don't do biopsy also. But for the pediatric point of view, we can't do repeated endoscopy because all our procedure are anesthesia dependent. So we can't give repeated anesthesia and to the child. So it's always better if you are suspecting any case of IBD, go with the upper GI along with the colonoscopy. Then complete colonoscopy is always mandatory for the diagnosis. So because that's what we can miss backwash hylitis, we can miss the extent of the disease or the complication if it is there, that we can be missed. So that's why if possibly we have to go with the complete colonoscopy with ileal intubation. So that to be done. Crohn's disease can present as a colitis, so that's why the biopsy plays very roles. So after doing biopsy or taking the multiple photos, we have to do the multiple biopsies also. So we have to take biopsies from the for the stomach, antral, duodenum, ileal. So all the possible areas, ascending, transverse, colon. So multiple biopsies is mandatory for the when we are doing the endoscopy for the our diagnosis. As Dr. Ekansh recently just now said, what are the findings we get in a Crohn's and endoscopic finding we get in a Crohn's and histopathology file. But this is very important to do the both the scopies. And that's what I think which is differentiate from the adults. So taking biopsy with upper GI colon, upper GI and colon is mandatory for the diagnosis of IBDs.
Yeah. So if it's an adult who comes with bleeding per rectum, doing a sigmoid or a colonoscopy might be sufficient. But in a child, once you have identified ulcers here, you need to rule out Crohn's, because Crohn's colitis is also something which is known to occur. So doing an upper GI is very mandatory. And hence, the point I want to highlight here is a child with suspected IBD needs to be scoped by a pediatric gastroenterologist who knows that you need to scope both upper as well as the lower one. And second, you need to take multiple biopsies, both from ascending, descending, transverse, and ileocecal junction. Needless to say, if the presentation, clinical presentation is such, then we would also like to take a gene expert sample to rule out tuberculosis. So multiple biopsies are to be taken, and that is how we make a diagnosis of IBD. So, so the next question here is to Dr. Prasad. What is the role of imaging in the diagnosis, prognosis, and monitoring of children with pediatric IBD, and what tests can be done, are usually done for these purposes?
Usually at diagnosis, one cross-sectional imaging of the abdomen is usually done. It can be either CT or MR enterography. So MR is preferred nowadays more and more, especially in older children, in fear of radiation in CT imaging. So in CT, what we see is one is extent of the disease. So especially the small bowel involvement may be missed in an endoscopy, where we are able to reach only till the ileum, and in the upper endoscopy till the duodenum. And also to look for complications of IBD, maybe a fistula or a stricture, which may help us to decide what level of treatment we need to start, whether we need to start from a top-down approach or a step-up approach. Also, the imaging will help us to differentiate intestinal tuberculosis from a Crohn's disease, which are the close mimickers. Like TB might have omental involvement or a necrotic lymph node or an ascites, compared to a Crohn's disease, where a long length of involvement of a bowel might be there. And on follow-up, nowadays we are moving towards a bowel ultrasound, where the multiple segments of the bowel is screened for the severity of the disease. So on follow-up, we might use bowel ultrasound to avoid repeated radiation exposure with the CT or cutting down on the cost of MRI, etc.
Yeah, so thank you for the succinct answer. And my next question now is to, because we're talking a lot on pediatric IBD, Dr. Shruti, what are the essential differential diagnosis in a suspected case of IBD, which also should be thought of? Because in any given clinical situation, one cannot be totally sure. So, what could be the differentials of IBD in children?
First, we start with the infections is something that we need to rule out. So infections, like we have discussed already, tuberculosis, because we know it is very similar in presentation and in other endoscopic findings as well. So we need to rule out tuberculosis. The other infections like Clostridium difficile infection, because again, the patient might have received multiple antibiotics. So we need to rule out Clostridium difficile and also cytomegalovirus colitis. Again, we need to consider the important part, that is the immunodeficiency, which can either be primary immunodeficiency or a secondary immunodeficiency, where like the primary immunodeficiency is like common variable immunodeficiencies, chronic granulomatous disease, and other secondary immunodeficiencies like HIV. We also need to rule out other immune and inflammatory disorders like celiac disease, eosinophilic enterocolitis, which can mimic and it can be very similar to ulcerative colitis, and less commonly like Behçet's disease and small vessel vasculitis. We need to know that solitary rectal ulcer syndrome also presents with complaints of bleeding PR. So we need to rule out SRUS in such a situation. And like we have discussed earlier, we know that irritable bowel syndrome can present in a similar way, where pain abdomen, loose stools, there can be present. So we need to rule out irritable bowel syndrome as well. This would be the large chunk of DDs that we need to consider when we are thinking of inflammatory bowel disease.
Yeah, so there is a whole list of differentials, as you can see, and in our own country, a very close differential, especially for Crohn's disease, would be tuberculosis. Needless to say, in ulcerative colitis with bleeding per rectum tenesmus and CMV colitis and C. difficile colitis needs to be ruled out. And of course, immune deficiency disorders for very early onset IBD as well as in old children. So now, having discussed most of the broad categories of IBD, I just would take our audience of pediatricians and pediatrician colleagues through two case scenarios, wherein we would just discuss how exactly this theory which we have discussed, we will put it into practice as well, such. So, so this child, a 9-year-old girl, presented with loose stools and pain abdomen for 3 months, with anorexia, weight loss around 5 kgs in 2 months, and fever for 3 months. Now, the fever was around 1 spike per day up to 101 degree Fahrenheit and persistent chronic pain. Loose stools were 3 to 5 days a week for the past 3 months. But there was no blood in stools. There was no mucus in stools. There was a history of oral ulcers present for a very, very long time, but there was no history of joint pain, rash, tuberculosis contact, and there was some improvement, transient improvement in symptoms with antibiotics. However, they recurred every time when antibiotics were stopped. As you can see, she was failing to thrive both in her weight as well as height, and there was some pallor present with clubbing grade 2 and aphthous ulcers on examination, but the systemic examination was normal. She was anemic, she was having thrombocytosis, the counts were high, the CRP ESR, as you can see, is high, the fecal calprotectin was very high. The LFT, liver function tests were normal, but albumin among that LFT was low, very low in fact, and the Montus test and HIV was negative, and the stool routine was normal, negative for ova and cysts. So with this background picture, as you can see, there were red flags and there were pointers in investigation. So this child underwent an upper GI endoscopy and complete ileocolonoscopy, and as you can see here, the upper GI endoscopy showed antral ulcers. You can see those aphthous ulcers. And there were duodenal ulcers as well. This is the second part of the duodenum where you can see these white basic ulcers. And there was, on colonoscopy, there was mucosal edema, loss of vascularity, and multiple punched out ulcers. These are very deep ulcers throughout the length of the colon up to the ileocecal junction, and there were multiple biopsies taken from these edges of the ulcers. And on histopathology, what was seen was cryptitis, crypt abscesses, and as you can see here, non-caseating granulomas. So these presence of these non-caseating granulomas is seen only in 30-40% of the cases, but if seen in such a clinical scenario, nearly confirms the diagnosis of Crohn's disease in this particular child. So the diagnosis is, of course, something that I've already told you. So sorry, Dr. Ekansh, you have to now talk about clinical pointers and what are the growth implications of this disease and why these implications are there. So please answer these two questions.
So, going prospectively, specifically for the interest of the pediatricians, that the child was coming to you with the history of chronic diarrhea, recurrent abdomen pain, there was presence of red flag signs. There was significant weight loss, there was growth faltering, there was pallor, there was some aphthous ulcers present. So any such child which comes to you with chronic diarrhea, not getting relieved on treatment with red flag signs, IBD needs to be kept as a DD, because not every child can be scoped, or you may not have a pediatric gastro available all the time, but such children where you find red flag signs and clinical pointers needs to be done. Apart from that, there was low hemoglobin, there was low albumin, thrombocytosis. That led us to do the endoscopy where the ulcers were present and the biopsy showed features of Crohn's disease. So talking about the growth implications, because it's a chronic disease, there's a persistent inflammation that is going on in the bowel that leads to the poor growth of the child. So needs to suppress that inflammation, and to also very important to have a look at the growth when we treat the child as well. Treatment wise, when you're dealing with IBD, especially in children, it is a step down approach. That is, we go aggressively for the treatment in the starting, and once the child may have some relief, we may come down on the treatment. And therefore in children in severe cases, actually we may start with biologicals right from the day one when we diagnose it. Apart from talking about the nutrition advice, we also want to start on enteral nutrition, sometimes in mild cases exclusive enteral nutrition. Also want to treat the micro deficiencies which are present. Also want to give them on a high protein diet. And also prognosticate wise, we have to tell the parents that it's a chronic illness, takes a long time to treat, and also there may be relapses in the future.
Yeah, so this is a chronic illness with waxing waning course like any other autoimmune disease, similar to diabetes in children. So the disease never goes completely, but you control it with medications. So this was the child on the time of diagnosis. As you can see, she has gained weight as well as height, and she is doing well post treatment. So the next question to Dr. Bhushan. How can one differentiate? We talked about Crohn's disease, as you saw in this last case, can easily be missed here because from the looks of it, it looks like a classical case of abdominal tuberculosis. So how do you actually differentiate Crohn's from abdominal tuberculosis, which is so common as well in India?
Abdominal tuberculosis is a close differential diagnosis for the IBD. So whenever you are diagnosing IBD, you have to rule out tuberculosis because we have to use steroids and multiple immunosuppressants. So ruling out tuberculosis is also mandatory. As this case, so you can see the chronic diarrhea is as a presentation. In tuberculosis, 40% they present as a chronic diarrhea. So abdominal in tuberculosis, but in Crohn's disease, 82% they present as a chronic diarrhea. So the percentage-wise chronic diarrhea is very common, higher percentage-wise seen in Crohn's as compared to tuberculosis. Blood in the stools very significant with the IBDs, Crohn's, as compared to the tuberculosis. So it had only 10% cases they present is a blood in the stool. Very common is a subacute intestinal obstruction or a stricture formation, which is very 20% was seen with the intestinal tuberculosis. Crohn's in a severe form, they present as a stricture. Otherwise, we don't get any obstruction complaints presentation. Yeah, extra intestinal manifestations are very commonly seen with the Crohn's. 22% cases they present with the extra intestinal manifestation that we have just read out. Ascites, yeah, very commonly. So along with the involvement is 30% seen with the tuberculosis. So ascites is very common with the tuberculosis as compared to Crohn's. Then we come to the endoscopic features. So as we said, so endoscopy, we have to rule out tuberculosis. So isolated ileocecal involvement. So other rest of the colons are normal, good vascularity, only isolated part is involved, then we strongly suspect tuberculosis. So 40% they present as an isolated lesion. Crohn's may present as isolated, but percentage wise only 8.7%. So that's how the endoscopic feature will help to differentiate between tuberculosis and Crohn's. Yeah, as we have read, longitudinal ulcers are very commonly seen with the intestinal Crohn's disease 48% as compared to the tuberculosis. There we get a 15%. So the thing, these are the few clues where we have to differentiate between Crohn's versus tuberculosis. So that's why we send the gene experts for all the biopsies, whatever it's suspect, taking for the ulcers.
Yeah. So, just to sum up the treatment options in Crohn's disease, it's a treat to target approach. We want the inflammation, the ulcers to completely heal. So we go from top to bottom. We go with a stronger drug initially. Inflammation is a culprit for poor growth in these children. Hence, deep healing is very important. And biologic therapies with infliximab, adalimumab, etc., and so many other biologics is now being used for Crohn's disease patient. Exclusive enteral nutrition, which is a form of therapy practiced in some parts of the world, is also one of the ways in which even severest forms of Crohn's disease can be taken care of, but they have to be for around 6 weeks to 8 weeks of completely on exclusive enteral nutrition of polymeric formulas. Now we have the advent of small molecules, which are the JAK kinase inhibitors, which are cheaper and are also very effective in the treatment. But the standard treatments initially when the child presents would be the use of steroids sometimes with azathioprine. But needless to say, nutritional deficiency needs to be corrected in all of these patients and regular growth monitoring. And this is one aspect of the disease where a pediatric gastroenterologist and a pediatrician mutually work together to monitor the growth and help improve the growth of these children. And surgery is very selectively required in pediatric IBD in these patients. Now, a very important question from pediatrician's perspective is the vaccination of these children. And I would address this question to Dr. Shruthi here. Dr. Shruthi, how would you like to vaccinate these children and what are the most appropriate time to do so? Which vaccines should be given priority and which ones are required annually for these children?
So first, once we have made a diagnosis of inflammatory bowel disease, we need to make sure that the child is up to date with the vaccination, especially the live ones, that is before we start with the immunosuppression. So we need to make sure that we give the live vaccines before we start the immunosuppression itself. And we also have to advise for the annual influenza vaccine. And more importantly, we need to make sure that the other household contact, like for example, if there is a younger sibling in the child, means if a sibling in the family who has not been vaccinated for chickenpox, we need to make sure that child is also vaccinated, especially the live vaccines, which can be even transmitted to the index case. So that, because we know that the index case might be immunosuppressed later, so and can contract the disease. So we need to make sure that even the household contacts are also fully vaccinated.
Yeah, so vaccination is important because we are immunosuppressing these kids. So avoid live vaccines once starting treatment. So if possible, under clinical circumstances, vaccinate them with live vaccines prior to immunosuppression, preferably giving them prior to initiation of therapy. But annual influenza vaccine, which is killed vaccine, needs to be done for all these children because they are going to be on long-term immunosuppression. Now, another case of a 12-year-old boy who had pain abdomen, periumbilical location with blood and mucus in stools for 10 days.
Excuse me, Nishant, sir. I do not want to intervene. I think we have 5 minutes left. So can you kindly?
Yeah. So 5 minutes. So I'll just have to quickly take you through this case of a. So this child had pain abdomen, tenesmus, and bleeding per rectum. Had been prescribed antibiotics, ofloxacin, metrogyl. The child did improve incompletely, and the stool routine showed RBCs, pus cells, and negative for C. difficile, and CRP was high. But because he continued to have blood and mucus in stool, was referred for colonoscopy, and this is how, as you can see, the colonoscopy pictures were different, and the biopsy showed active inflammation with creptitis. The diagnosis was ulcerative colitis, and the treatment options available again are the immunosuppressive agents. We have already discussed there is a role of upper GI endoscopy in a suspected case of ulcerative colitis, because we know that in ulcerative colitis, while there's only a colonic involvement, Crohn's colitis can be also presenting sometimes like this in children, wherein you would like to rule out an upper GI involvement. So in ulcerative colitis, the treatments are steroids and 5-ASA along with azathioprine and biologics. So as you can see, the treatment regimes are similar, but the drugs used are different. Now, this case particularly I had kept is how usually a very early onset IBD usually presents. I'll quickly take you through. This is a boy who was a good weight boy, exclusively breastfed, gaining weight till 10 months of age, and then developed fever, loose stools, blood and mucus and vomiting, and no response to antibiotics. Was suspected to have milk protein allergy. Milk was stopped, milk products were stopped, and but the blood and mucus persisted. As you can see, there was anemia, thrombocytosis, inflammatory markers were raised with hypoalbuminemia and raised fecal calprotectin. So under this background, and evaluation for primary immune deficiency subset was normal. This is the picture where you can see the whole colon riddled with, as well as the small bowel riddled with numerous ulcers, which were classically as seen in. So you can see a 10-month-old boy presenting with features classical of inflammatory bowel disease as well. So you can have IBD in very young children as well. Whole exome sequencing was done, but there was no abnormality detected. So this is a typical case of a very early onset IBD, but it is different from the usual IBDs because it's a monogenic IBD usually, which behaves differently than the usual IBD. And that is why a whole exome test is required to look for certain primary immune deficiency disorders, which can present like this. They behave clinically very, very different from the older age group IBDs, and they are very, very difficult to actually manage. But that is why you would require inputs from your hematologist in many of these cases, because many primary immune deficiency disorders will present very similarly to very early onset IBD presentation and in such a form. There are certain forms which are curable, and these are, for example, IL-10 or IL-10 receptor mutations, which are amenable to BMT, as is the chronic granulomatous disease. And so you would, in a way, can cure a very early onset IBD in very special circumstances by doing a bone marrow transplant. So, to sum up, and this is my take-home message for all my friends here. And before I thank my esteemed panel here, I would just sum up what all they have discussed today in the last 1 hour. The inflammatory bowel disease incidence is definitely on the rise. As pediatricians, we need to know about it to be able to pick it up, the red flags in our OPD practice. It affects both rural and urban population. So thinking that it's only a disease of the urban population is wrong. It can affect children of all socioeconomic strata. Consider IBD early in children with red flags. So we have discussed red flags. Keep it on your table and look for red flags when you are suspecting IBD. Growth failure is a critical diagnostic clue. So children who are not failing their growth, think of IBD, think of Crohn's. While you're thinking of celiac disease, please also think of Crohn's disease, which can present in a similar fashion. Now, earlier the diagnosis of IBD is made, better the management, better are the outcomes, because this disease severely affects the growth of the children, especially Crohn's disease. And that is why if the inflammation is not corrected early in the course of illness, it can severely hamper the overall growth potential of the child. There is a bimodal presentation, as we mentioned, adolescent age group as well as younger age group. So high index of suspicion required when these children hit the puberty. It requires both upper GI and colonoscopy for diagnosis. And one point I just want to highlight here is that inflammatory bowel disease is a more severe, more extensive disease in pediatric age group as compared to adults. So, and that is why many of these children, if they land up with an adult gastroenterologist, they are usually treated with milder disease, milder medications, milder drugs, and hence do not improve, because this one disease is more severe, more extensive in children as compared to adults, and hence requires a higher use of stronger drugs or biologics, etc., top-down approach, as we discussed earlier. Treat to target, eradicate the disease. That is the motto. We need complete eradication of the disease, and that is when the growth will occur. And as pediatricians, we know that how important is the growth and development in any child who comes to us with any disease for that matter. Pediatricians are the central pillar who are responsible for the long-term care of these children, be it vaccination, be it growth monitoring, be it nutritional supplementation. So a pediatric gastroenterologist is dependent on his pediatrician friend for the complete management of these children. A pediatric gastroenterologist can help you make a diagnosis, but the total management, holistic management of this child would require a 50-50% partnership between a pediatrician and a gastroenterologist, pediatric gastroenterologist. So the disease has relapses and remissions. So this is something which we need to tell the parents at the time of diagnosis, because there will be good times and then there will be bad times, similar to, say, for example, nephrotic syndrome. And pediatric gastroenterologist is always available for shared management, and I would urge my friends there. And now this is a growing branch, and this has now a robust number of pediatric gastroenterologists across pan India, in Gujarat as well, and you have one in all major towns. You can have their expertise available to you and help make the lives of children with IBD much better, and they can be treated much nicely now than ever before. Thank you so much, and thank you, esteemed panel.
Thank you, sir.
Excuse me, sir.
Thank you.
So there is a question in chat box. Indications of giving biological like infliximab and adalimumab in IBD. This is from Dr. K. Suri Babu.
Yeah. So indications. Well, the severity of the disease. So as I mentioned, initially the treatment of Crohn's disease used to be giving steroids, tapering them, putting them on something like azathioprine, and then seeing whether the child is improving or not. However, now it has been found that moderate to severe disease in Crohn's disease, this regime will result in more relapses than ever. So, biologics are now used even initially at the time of diagnosis in moderate to severe disease to help achieve a remission early in the disease course. Because, as I mentioned, you hit early and you completely eradicate the disease, and thereafter you can actually tone down. So, you start with a biologic and you actually tone down the dose of the biologic over the next 1 to 2 years or maybe more. Sometimes we have to change the biologic where there can be various reasons for those. I won't go into the details, but this is one indication. Moderate to severe disease, you start with a biologic. The other indication, of course, is a child who is doing well on regular immunosuppression. And as he grows up, like I mentioned, puberty and beyond is the time when the disease can worsen. So you might have a child who is doing well on AZA, but now is not doing so. You might have to shift to a higher step of using a biologic in these patients. So, these are the indications for using biologic in patients. So, any other questions?
No, sir, not in chat box. Anyone who wants to ask any question, kindly unmute him or herself and then ask, sir.
One question, sir, is already answered. If father is
Yeah.
having ulcerative colitis, could it be
Yeah.
inherited? So, but yes, genetic predisposition, which sir has already written.
Sir, one more question from Jankana ma'am. When there is one child is immunocompromised, any household contact cannot be given live excreting vaccine, that is OPV. If given accidentally, then that person should be. This is just a comment from madam, I think.
Very true. Very true.
How common you see IBD? Please name yourself whenever you are asking question.
Yeah. So, how common do I see IBD?
Yeah.
Do my panelists would they like to answer?
So please stop the screen share now. Yeah.
Okay.
Here in South India, in a place like Mangalore, I'm seeing very commonly. In last 2 years, maybe newly diagnosed Crohn's disease, especially maybe 30 to 40 new cases we have diagnosed and they are on treatment. And most of them are doing good with the good management. Few of them are on biological therapy, like maybe 10 to 12 cases are on biological, mostly infliximab. They're doing good. Ulcerative colitis less common. Maybe I have around 4 to 5 cases of ulcerative colitis in last 2 years compared to Crohn's, which is much more common here.
Yes. So, over my last 20 years, where I've been seeing IBD, and I must say 15 years ago, we used to feel that ulcerative colitis was more common in North India. But in North India as well, now we find more cases of Crohn's disease as compared to UC. And the numbers have been steadily increasing. But what I have seen, from a gastroenterologist point of view, I do diagnose new IBD, two new IBD cases every 7 to 10 days. So they do come to me. And but having said that, I think that would not be the true picture because there is a referral bias. As a gastroenterologist, we would always give you huge numbers. Having said that, yes, the numbers have risen. The severity has also risen. So my patients 15 years ago, if I could manage them with steroids and azathioprine or 5-ASA, the ones who come now are much more severe and much younger in age group, and they would require a biologic at the outset when they are being diagnosed. So that is definitely changed. The severity of disease has increased. The numbers have also increased. So both of those things have happened in India over the last 15, 20 years. So,
Yeah, thank you so much,
Thank you.
moderator sir, and all the panelists, Dr. Nishant Wadhwa sir, Dr. Prashant sir, Dr. Shruthi madam, Dr. Bhushan sir, and Dr. Ekansh sir.
Thanks
Such
a
a
lot.
wonderful
Thank you.
discussion. Our
Thanks
Digan
a
Shastri
lot.
sir has also mentioned that to the point discussion and great going. Thank you so much. Digan Shastri sir is always there when we are all getting motivated by him and his presence. So now
Now I have restarted my MD. So that's why I am joining the e-Gurukul every time. Because 40 years back I passed. So I need to learn the new things. Thank you.
Sir,
Thank you.
here caveat will be there. No one will be from the organizing team will participate in the quiz.
No, they can participate, sir, but last 5 questions, they will not participate, so we'll not give them the prizes. But let them play, not an
Yeah.
issue. So last 5 questions, they will not participate.
Yeah.
So I think, should I start now the quiz? The quiz is very simple. It's on Kahoot platform. And as we have put the link in the chat box, you have to open by clicking on that and you will be able to see the screen. Few names have already joined. We just wait for a minute or two, and by that time I'll just tell you the rules. The rules are simple. It's fastest finger first. The questions are from the GI. All questions will have 4 answers. The answers will be in 4 color codes: green, blue, yellow, and red. You have to select the correct answer those who select fast will be given more points. And even if your answer is right, but if your speed is less, then you may get the less marks. It's simple. Either join by the link which has been posted in Zoom. I hope my screen is visible.
Yes, sir.
Yeah.
It's visible. Huh.
Yeah. Or, yeah, 41 out of 77. Nishant sir, your presentation was such that at one time we were having 88 people, and out of that 44 have joined, 50% have already joined. So join by either kahoot.it and enter this game pin, or you can just screen the QR code which is visible. And I'm glad to share that for this quiz, we are giving 15,000 cash prizes. The first prize of 3,000, second prize of 2,000, and next 1,000 rupees 11 prizes. And for this, we are thankful to Zorvia Healthcare. And I think from Zorvia, Mr. Alhad is there. If you can just speak for a minute or two, then we'll start the meeting.
So first of all, thank you so much. On behalf of Zorvia, let me thank Academy of Pediatrics Gujarat for giving this an opportunity. Dr. Yogesh Parekh sir for associating Juventus, allowing Zorvia to be associated. Dr. Lata Jha and Dr. Sandeep Trivedi. And moreover, sir, Dr. Prasad Karya for giving us an opportunity to be associated. Zorvia is an organization which we have just formulated. As of now, to be in language of pediatrics, we are just toddlers with big dreams, and we would request all of you for your support and good wishes for Zorvia. We have 3 Zs which we have already launched in the market. We have Zorvin Kid, we have Zorberry Drops, and we have Zincase. These three brands are available. Our field force will definitely come to each one of you and express and promote these products. But we would look forward to your blessings. To all the participants, best wishes, and we hope that all are winners. And we are here, and we are here to support academic efforts and initiatives of Academics of Pediatrics Gujarat. Thank you so much. We also have Sir Shailendra Mishra, who is our sales manager for West, and Abhishek Kanyalkar, who would be taking these topics ahead, sir, in terms of association.
So thank you so much.
Thank you so much.
And with the permission of ma'am, should I start the quiz now? Because the people can start joining by entering the game pin, but we should start it now.
Yes.
Okay. Yeah. So it's a simple quiz. First 2 questions are a poll questions, which is not having any marks because many of you are playing for the first time on Kahoot. See, the question will come like this. The most powerful medicine in pediatric practice is. You are given 20 seconds to vote. Broad spectrum antibiotics, vaccination, multivitamin syrup, and reassurance with confident body language. Now 53 answers came in around 10 seconds only, but we will wait for the 20 seconds. And yes, 34 are given a answer, reassurance with confident body language and vaccination. All the answers are just for a fun. Second poll question, you have to play like this. If the child comes with a history of fever for 2 days in OPD, playing and running all around, which dialogue fits best? डॉन को पकड़ना मुश्किल ही नहीं नामुमकिन है. All is well. लुका छुपी बहुत हुई and आज मैं ऊपर आसमान नीचे. This is a combination of a song and a dialogue. So yes, you people are playing well. 62 answers, 63 answers in perfectly time, well in time, and 44 all is well. Yes, this is a perfectly well child. So all the best to everybody. I hope everybody is geared up now. So real questions for the real mark starts now. And the first question. What is the most common cause of acute diarrhea in children? E. coli, Giardia, Shigella, or rotavirus? For this, because this is the first question, the total time given was 30 seconds, but in 10 seconds, 67 answers are already there. Even if you are right, but if your speed is less, the marks you get will be seen on your screen, will be less. But 70 people have already answered it. And the correct answer given by 62 is rotavirus. Perfect. And the fastest answer given by is Z. Now remind you, the marks which you are getting, you have to preserve the screenshot and you have to send it at the end, because you all have written your simple names or screen names, TKB, Dipti, RSV, Shiv, because for transferring the cash prize, we will need your details. The next question. For how many days should zinc be given in case of acute diarrhea? 1 month, 10 to 14 days, 5 days, 3 days. Yogesh bhai, the people are so fast that in 7 seconds, 70 people are answering.
Gen Z.
Gen Z, yeah. And then I should have kept only the duration of 20 seconds so that this finishes fast. But then yes, 71 answers are already there.
Next time you take only 10 seconds or 15 seconds only.
No, sir. See, these are the few initial questions because we are playing for the first time. Some hard questions will come. Wait for the time. Yeah. Okay. But again, Z is still at the top. A to Z. Gen Z. What is the most common cause
game
of
pin kayo માંગે છે game pin?
chronic constipation in a children? Cow. Celiac disease, hypothyroidism, functional constipation, and Hirschsprung disease. So the game pin is when you enter kahoot.it, નીચે લખેલું છે kahoot pin માં 947682 is the game pin. Lata ma'am, if you can just type it down again in the chat box. 947682. So functional constipation is the perfect answer given right by 63 people. TKB is climbing. If I'm not wrong, Akshat is the secretary of Surat Pediatric Association and he's a tough guy, always giving a competition. Yeah. Next, which of the following is a red flag in constipation? Painful stool, stool withholding, onset since birth, and hard stool. I can see Jigen smiling. દરેક વખતે પ્રાઇઝ લેવી હોય છે જીગેનને.
ભાઈ મારું કનેક્શન લોસ થઈ ગયું એટલે હું બીજો ક્વેશ્ચન આન્સર ના આપી શક્યો.
So સારા નેટવર્કમાં રહો જીગેનભાઈ.
That is more important.
એના કરતા એમ કે અમારા નેટવર્કમાં રહો.
તમારી જોડે જ છે સાહેબ હવે.
નહીં, તમારું નેટવર્ક સારું છે.
So see, basically red flag in constipation is like onset since birth is actually a red flag. Painful stool, stool withholding, and hard stool may be there. But if it is onset since birth, before going to the quiz, can somebody write down in chat box what is the, or just unmute and say onset since birth constipation, what is the commonest diagnosis?
Hirschsprung.
Hirschsprung, perfect. Yeah. Akshat, I said Akshat is a tough guy to give competition and he is at the top now, followed by Pawan and Nikita. Next question. A 14-month-old brought to ER with acute abdominal pain, and according to the age-based diagnostic compass, last times, what is the commonest diagnosis? Intussusception, dysmenorrhea, mesenteric adenitis, and acute appendicitis. This was said by Dr. Vibor last time, the diagnostic compass according to the age. And this is a 14-month-old child with acute abdominal pain. (62) are correct. It is, yes, intussusception. That is the commonest at this age. Zaz is coming up, followed by a Curosurf. I don't know why you are advertising a brand. But fine, good. Okay, next question. What is the most common cause of neonatal cholestasis? Sepsis, hepatitis, CMV, or biliary atresia? And this is easy because in between I have kept some easy questions so that we can have some breathing space. And 80 answers are already been there. And the correct answer is biliary atresia. See, commonest cause of neonatal cholestasis. It is there. Okay. Next, what is the most common cause of fatty liver in adolescents? Hepatitis A, non-alcoholic fatty liver disease, typhoid, and Wilson disease. It's very good. 69 people are right. It is non-alcoholic fatty liver disease. And the score is now Zaz at the first. Next question. When triaging a child with abdominal pain and vomiting, which symptom sequence suggests surgical cause? Pain occurring before the onset of vomiting, vomiting occurring before the onset of pain, pain and vomiting begin simultaneously, and pain that resolves immediately after vomiting. Mind you, it is which of this suggests surgical cause, the symptom sequence. "79 answers, and of that, pain occurring before the onset of vomiting is actually a surgical thing which has to be there. And now ZH, JH, Z, ZES, and MJP. All this are new faces. Let's see. Next question, a double point question. In managing severe acute pancreatitis, what is the recommendation for the route of nutritional support? That delay all feeding until serum lipase levels have completely normalized, prefer early enteral nutrition over total parenteral nutrition, only nasojejunal feeding as nasogastric feeding is unsafe, and utilize TPN exclusively to ensure complete bowel rest. Again, this was said in a last panel discussion in which Dr. Vibor was the moderator. And it was beautifully said that whenever you are managing a child with severe acute pancreatitis, you have to actually prefer the early enteral nutrition over total parenteral nutrition. That is the most important thing. Now the MJP is the top, followed by a Curosurf. Next, again double point question. Which of the following serves as a criteria for renal failure when assessing organ dysfunction in pediatric pancreatitis? Presence of protein in the urine, blood urea nitrogen, urine output for 6 hours, and blood urea nitrogen and creatine after adequate rehydration. Again, a question from the last panel discussion. "77 answers are there. Waiting for a few more to participate. 81. And 54 are right. So this is good that you have to actually adequately rehydrate, and then you have to see the blood urea nitrogen and creatine. I think few of you have left the Zoom meeting because this actually needs 2 screens, but then this Kahoot will be visible on your Kahoot platform. Once you finish it, please join the Zoom again so that we can come to know who are the winners. Yeah. Next, Eddie Brevo. IRK and Akshat is again back, followed by Aditi. Yeah. The next. What is the recommended approach for using antibiotic in pediatric acute pancreatitis? Antibiotics should be reserved for prone extra pancreatic infection or necrosis. Always provide additional prophylactic antifungal coverage. Start antibiotic immediately if serum amylase is high, and prophylactic broad spectrum antibiotics in all cases of necrotic pancreatitis. Now, the question is slightly tricky and made in such a way that it gives you 81 answers are already there. So waiting for few more. Yeah, actually you should reserve it and use only in case of a proved extra pancreatic infection or necrosis. So that is the most important thing. Okay. Next, Aditi is climbing up. Which antibody is the best initial screening for celiac disease? Anti-TTG IgA, IgE, anti-gliadin, or ANA? So 78 are perfectly right. So I mean, out of 78 and 5, 83, 5 people have given the wrong answer. Rest all are right. So anti-TTGA is the correct answer. Okay. Going further. What is the classic triad of intussusception? Pain, red currant jelly stool and mass. Pain, vomiting and fever. Diarrhea, mass and fever. Constipation, fever and pain. So again, 81 out of 83, 81 are perfectly right. It is pain, red currant jelly, stool, and mass. So I think the audience is really playing very well. Let's see. So the AD Bravo is now at the top, followed by MJP and Akshat. An 8-month-old infant present with inconsolable crying, high-grade fever, jaundice, and pale stool. The most likely diagnosis is hypertrophic pyloric stenosis, acute viral gastroenteritis, Meckel's diverticulum, or biliary obstruction or cholangitis. Again, in 10 seconds, we are having 78 answers. Waiting for a few more. Perfect. Again, out of 85, 77 have given a correct answer. It is a biliary obstruction or cholangitis. So the audience is playing very nice. And we are happy to see all this right answers. The next, what is the most common IBD? Just a minute. Don't answer this. I'm just skipping this. There is some issue with this. Yeah. So I'll just go to the next question. A child with chronic liver disease and KF ring points to which diagnosis? So the diagnosis is hepatitis A, biliary atresia, Wilson's disease, or autoimmune hepatitis. And the 81 answers are there in 9 seconds.
We will answer in 5 seconds at this rate.
Yeah, that is what I'm saying. We are getting answers in less than 10 seconds. So next time, maybe we have to decrease the time.
Yeah, 15 seconds will be enough.
Yeah. No, but the Kahoot gives 81. I mean, out of 82 answers, 81 are perfectly right that it is a Wilson's disease. Only one answer of autoimmune hepatitis. And this may be just in a hurry. Somebody has clicked that. That may be the thing. Okay. So the Eddie Bravo, MJP, Akshat, Aditi, and TKB. Now somebody has to come up 5 places. PS is the highest climber. Okay, coming to the next question. In infant with suspected surgical emergency, which red flag is currently matched with its underlying pathology? That is most important, and you have to identify it. Absent bowel sounds with simple constipation, involuntary rigidity with peptic ulcer disease, bilious vomiting with midgut volvulus, and current jelly stool with pyloric stenosis. Which combination is actually perfect and identifies the underlying pathology? So out of the 83 answers which we received, 78 are perfectly right. It is a bilious vomiting and midgut volvulus. Nishant sir, now your questions will be coming most probably from today's session. This was regarding all the past sessions. No, Ajit, still more. What is the best method to diagnose biliary atresia? Liver biopsy, USG abdomen, MRCP or CT abdomen? So always 81 answers comes in 10 seconds and then we wait for a 1 or 2 more answers. Nishant sir, your take on this, because only one answer is remaining. Or any faculty participating. Hello? Hello? Is my voice audible?
Yeah, go ahead. Prashant, go ahead.
Okay. So liver
Yes,
biopsy was
sir.
the correct answer. Yeah, fine. Okay. Double point question. In infected pancreatic necrosis, which antibiotic class is preferred for its strong pancreatic tissue penetration? First generation cephalosporin, penicillin G, aminoglycosides, or quinolones? Yeah, so the perfect answer is actually a quinolones. This was said in a last presentation while in a panel discussion we were discussing this. Okay, coming to this. Yeah, now what is false regarding the incidence of pediatric IBD in India? Pediatric Crohn's disease is more common in South India as compared to North India. Ulcerative colitis has bimodal presentation with a peak in adolescent. IBD does not affect children less than 6 years of age. And incidence of both pediatric Crohn's disease and pediatric ulcerative colitis is increasing. You have to identify what is false regarding the incidence of pediatric IBD in India. Perfect. 50 people are actually right that IBD does not affect children less than 6 years of age is the wrong. I mean, it's not correct. Fine. Coming to the points. Now IRK has come up. Akshat, Darsh, MJP, Eddie Brevo, IRK. Next. All of the following are true regarding pediatric IBD management except colectomy is required in almost all cases of very early onset IBD. Both upper GI endoscopy and colonoscopy should be done in all suspected cases. Relaxing remitting course requiring long-term maintenance therapy. And CT-MR enterography defines disease extent and detects strictures in pediatric Crohn's disease. So all are true except one, which was said in today's presentation only. We got 78 answers, 79. And the correct answer, perfectly, everybody has listened to Nishant sir perfectly, and everybody is almost right that colectomy is required in almost all cases is the wrong answer. Okay. Next, a double point question. All of the following differentiate pediatric Crohn's disease from intestinal tuberculosis except joint swelling and pain, uveitis and aphthous ulcer are seen in tuberculosis. Isolated ileocecal ulcers favor intestinal TB over Crohn's disease. Subacute intestinal obstruction is more common in TB than Crohn's disease. And chronic diarrhea with blood in stool is more common in Crohn's disease than tuberculosis. There is shown a beautiful table in which he has said this. Yeah, so again, majority are right that joint swelling and pain, uveitis and aphthous ulcer are seen in tuberculosis is the answer. Yeah. Now Akshat is at the top, followed by MJP and Darsh. This is second last question. Which are the lab parameters towards IBD in children? Increased CRP and ESR, normal hemoglobin, normal albumin, and thrombocytopenia. "76 answers came till now, waiting for a few more. Come on, friends. Yeah. So again, out of 77, 70 are right. It is increased CRP and ESR. So perfect. Akshat, MJP and Darsh, a tight competition. Last question. A double point question. Which one of the following is false? Doctor should preferably give live vaccine prior to initiation of the therapy. IBD does not affect children in first year of life. Pediatric IBD can present in various ways. Pediatric IBD incidence is rising in India. So out of 74, the correct answer is given by 51, that IBD does not affect children in first year of life. This is false things. So before we come to the result, this is a poll question for everybody. How was the quiz? A very easy, hard, or very hard? Now this will not give you any marks, but this will help us so that we can prepare the quiz next time in a better way.
Easy for those who attended the sessions.
Yeah, so this is what the result
to
also
make it
says.
very easy, attend all the sessions of e-Gurukul with concentration. Then it will be very easy.
Yeah, so now the perfect time for the winners. First three winners will be displayed initially on the podium, and then we will show you the full list of the winners. But the third person on the podium with 24,000 is MJP. Second is Darsh. And first, I think it is Akshat. Yeah, it's always Akshat. He was our student, and since then, he is almost winning all the counts. And these are the other winners. I'll just take a minute and we'll just, yeah, just give me a time to show the other winners also, those who are getting the full prize. And yeah, so this were almost correct answers were given by around 41% view full report. Yeah. I'm just sharing the screen so that everybody can see. Can you see the screen result?
Yeah, we can.
Yes.
So there were around 127 participants. I mean, intermittently the people were playing. Akshat was first, followed by Darsh, followed by MJP, then Sitara, Aditi, SK, Shubhashri K, Rajesh, Dr. Aditya the Great, The Curosurf is Prithvi, IRK is RK, and then the Vijendra. So till 11, Yogesh bhai, till 11 we will, to first Akshat we will be giving 3,000 rupees cash prize, to Dash 2,000 rupees, and to then 3 to 11 all will get 1,000 rupees prize. So congratulations to all the winners.
Thank you.
And yeah, 127 total participants were there, but then as Jigen said, somebody might have left the quiz in between or some network issues. So over to the team for the, so you have to send screenshot with your GPay number to us on our email and mobile number both. I'm just sharing so that you can just share it and we can just transfer the money. Yeah. Over to ma'am.
Thank you. Thank you so much for a very wonderful session. Both the sessions actually. First session by the moderator with the our tummies which are hurting, and the second session with the recall of all the e-Gurukul sessions till now. So with this, I thank our Digan Shastri sir, Yogesh Parikh sir to be here, Lata for moderating it very nicely, and our moderator and panelist, Dr. Prashant Karya, for making the quiz, formatting it from all the sessions, and then conducting it very nicely. Sandeep Bhai joined, but then he left. Our Vice President, Dr. Jigen Shah, he's still here, and I know he must not be feeling good because he generally want to win the quiz. So Jigen, better luck next time. So attend the e-Gurukuls every time.
Sure, ma'am. कोची मीटिंग રાખજો તો અટેન્ડ થશે બધું.
And Jankna madam, thank you so much. All the participants, all the students, even the doctors who joined from all over the India. And we would love to have more sessions. Next year, next month is for CNS. So go start preparing your CNS, and we will be having the CNS panel discussions with expert talks, the case presentations, and again the quiz. So thank you all for participating and rejoining us.
Nehal Ben, we should thank the sponsors, our who have supported this activity, because again, winning a prize of even a 1 rupee is also very special to the winner. So they have been generous. So thanks to the sponsor also.
Thanks to the Zorvia, definitely. They were always ready. But the most important thing, what we learned, Digan bhai, કે બધા લોકો 10 સેકન્ડ માં આન્સર આપી દે છે.
Yeah, but then, so next time you have to either make the little question little tough, or you have to reduce the answer
sir,
and
today we have taken only 24 questions from the last 4 sessions. So 6 from the all, and few questions were very easy. So that's why we just kept. Yeah. So I think we can keep 20 questions. That will be okay.
So it's a learning for quiz master also.
Yeah, definitely. Always. That's why I always ask, how was the quiz? If I get very hard, then I'm a bad quiz master.
So Zorvia, thank you so much for supporting this activity as an academic partner and motivating everyone to learn and update the knowledge. Thank you so much.
Thank you, madam.
Thank you. So,
Thank
sir,
you.
should we end the meeting?
Yes.
Chancellor, thank you so much for staying till end. It was pleasure to have you. Again, reminding, please either send on WhatsApp or email so that we can transfer the money, the prize, cash prize. So thank you so much.
કોઈ ના આવે તો
આપણને આપશે.
તો એઓપી ગુજરાતની ફાયદો એટલો.
કેરી લિસ્ટમાંથી આમ ઉપર આવવું જોઈએ.
ના સર, દર વખતે આવી જ જાય છે, લોકો મોકલી જ આપે છે.
Okay.
Good night everyone.
Good night.
Good night, everyone.
Thank you.